Good morning. Mihir, are you going to be starting?
Harshdeep will start. Good morning, ma'am. Ma'am, I am
Yeah.
Harshdeep.
So,
I will be starting.
okay, Harshdeep, just find out from Dr. Sareen and maybe you could start.
Yes, ma'am. Good morning, sir.
Yeah, you please
Sorry, sir,
start.
can we start?
I'm on my way. Please start.
Is my sound audible and my screen visible, sir?
You
Yes,
all can
Harshdeep,
start.
please start.
Shabnam and Harshdeep.
Good morning,
Screen is
everyone.
visible, you're audible. Just start. Yeah.
Good morning, everyone. Myself, Dr. Harshdeep, me along with Dr. Meir and Dr. Shabnam from Tata Memorial will be presenting today's word rounds on the topic carcinoma nasopharynx. The slides are not moving, ma'am. Just a second.
So somebody can look into that while you can go ahead and keep talking. And one of your other colleagues can look into this issue of the slides not moving.
Right. I will be starting now. So here's the case of 25-year-old gentleman who is a resident of Uttar Pradesh, currently residing in Kalyan since 5 years. He's a hardware engineer by profession with no addictions, no comorbidities, and no family history of any malignancy. He presented to Tata Memorial Hospital in March 2024 with chief complaints of bilateral swelling of neck since 6 months. He also had complaints of occasional bleeding from the right side of nasal cavity before 6 months. He had complaint of pain in right ear associated with decreased hearing since 6 months. Coming on to history of presenting illness, patient was apparently all right 7 months back when he noticed swelling over the left side of neck. To begin with, it was initially localized to left lateral side of the neck, and over a period of 1 month, he started developing swelling over the right side also. It was initially painless to begin with, about 1 centimeter in size, and partly responding to oral and topical medications. But however, eventually became painful and not responsive to medication and progressing to the present size in the last 6 months. The swelling was hampering with daily activities, making it difficult to carry out day-to-day activities with ease for the patient. There was no history of rapid increase in the size of swelling or any redness or ulceration of the overlying skin. Patient also had complaint of spontaneous bleeding from right nasal cavity, which were few drops of blood, and he had 2 episodes of the same. He also had complaint of pain in the right ear, which was associated with decreased hearing from the right side since 6 months. There is no history of any nasal obstruction, no history of nasal congestion or discharge. There is no history of hyponasal speech or no history of any trauma to the nose. There is no history of tinnitus or vertigo. There is no history of parosmia, diplopia, facial pain, vertigo, or difficulty in swallowing. There is no history of any hoarseness of voice, no history of fever, night sweats, no history of loss of appetite, bone pain, cough, hemoptysis, or respiratory distress of any sort. There is no history of pain per abdomen, yellowish discoloration of eyes, and there is no history of headache or neck stiffness.
So, okay, Harshdeep, 1 minute, go back to the slide. So, you know the reason why you elicited all this negative history?
Yes, ma'am.
Okay, so no history of nasal obstruction, nasal congestion or discharge, hyponasal speech, trauma to nose. Why?
Ma'am, as the patient presented with the symptom of bleeding, so I wanted to rule out whether there is any obstructive cause to the nasal cavity. So if there was any mass or anything which was obstructing the nasal cavity, he would have presented with the following symptoms.
Okay, then what about tinnitus, vertigo?
As the patient is having a decreased hearing from the right side, so
Hmm.
wanted to rule out the eighth nerve symptoms, whether it is because of any conductive cause or whether it is due to any cranial cause of hearing, decreased hearing.
Vertigo?
The eighth nerve involvement, madam, cranial nerve
Okay.
is.
Then parosmia, diplopia, facial pain, vertigo, difficulty in swallowing.
Uh, Starting
So
from
1 minute,
parosmia.
Harshdeep, 1 minute, Harshdeep. If there are any other TMH residents who are there, you all can also answer, because it should not be only the people who are presenting know it in and out and the others are only what you call passive spectators. Please participate. Yeah. Okay. Go ahead, Harshdeep.
So, no history of parosmia to rule out olfactory nerve involvement, whether if there is any diplopia for
But
optic
why
nerve.
did you think of olfactory nerve involvement?
As the patient is having complaint of bleeding through nose, so it is situated nearby to the to rule out the local cause, ma'am. If there is any
Okay. Okay. Maybe acceptable. Then diplopia.
diplopia, oculomotor nerve involvement, ma'am.
Oculomotor nerve involvement. Is there any other cause for diplopia? What are you suspecting? Like you've extensively evaluated, taken history, examined the patient and all that. So what are you thinking about? Diplopia, oculomotor nerve involvement. When does diplopia occur?
There can be either the local cause, that is a muscle involvement due to a
Hmm.
mass, that is
Hmm.
atelectasis, or there can be any nerve palsy which can cause diplopia, ma'am. Or
Yeah, so
can then
diplopia is typical oculomotor nerve serves, I think what you call supplies which external ocular muscles, extraocular muscles. So when you're answering, keep that in mind. So diplopia, typically, if you're suspecting this patient, just because we know it as a nasopharyngeal cancer patient, what will be the nerves that will be involved to cause diplopia is what you have to keep in mind. Okay.
yes, ma'am.
Then facial pain. Why do you want? Why do you think patient could have facial pain?
Ma'am, if the
And
patient is like we are suspecting in is a nasopharyngeal carcinoma, the nasopharyngeal carcinoma can invade foramen rotundum and it can involve that
Which nerve?
maxillary nerve.
Which nerve?
Maxillary
Yes,
nerve, ma'am.
yes.
Maxillary.
Okay. So V1, V2, V3, huh? Which
Yes,
nerve?
ma'am.
Yeah. ठीक है. Then
It,
vertigo, you've already talked about difficulty in swallowing. Difficulty in swallowing will come in nasopharyngeal cancer, especially. I don't know what the diagnosis is. When will you have difficulty in swallowing in a case of nasopharyngeal cancer?
when
Which nerve has to be involved?
it is extending into oropharynx involving vagus nerve.
It will have to be the lower cranial nerves, right?
Yes, ma'am.
Yeah. Okay. Now you said history of home, because you've got a long list of negative history. So you need to know all the reasons why you have taken. Now you've said no history of fever, night sweats. What else can be the case here because you think there was fever and night sweats?
It can be tuberculosis as well as lymphoma also, ma'am,
Yeah.
in the same
Okay.
age.
Then loss of bone pain and loss of appetite.
Here in this case, the hematological spread mostly will be
Okay.
common to the
Then history of
bone.
cough, hemoptysis, respiratory distress, abdomen, no pain in abdomen, yellowish discoloration of eye, headache, neck stiffness.
The pain abdomen yellowish discoloration will be to the we are ruling out liver mets, ma'am,
Oh
and
God. Yeah.
head, neck, and neck stiffness due to whether if there is any intracranial extension, we can clinically suspect that.
Neck
And neck stiffness,
stiffness.
posterior involvement of prevertebral muscle can lead to neck
Very
stiffness.
good. Very good. Very good. You could answer all these questions on the negative history. Okay, go ahead. Go ahead.
Then coming on to past history, there is no history of any medical illness in the past, and there is no history of any tuberculosis or contact with any known cases of tuberculosis. Coming on to personal history, the patient takes mixed diet with adequate sleep with 7 hours a day, with normal bowel and bladder habits, and denies any addiction. In family history, there is no history of any malignancy. Coming on to socioeconomics history, he belongs to upper middle socioeconomic class according to modified Kuppuswamy scale. Lives in a joint family of 4 members in a pakka house with inbuilt sanitation facilities, and he has completed education till graduation with an average monthly income of 40,000, with both parents being the earning member in a family. Now coming on to pre or baseline examination findings. Patient is conscious, cooperative, and moderately built and nourished, with well-oriented to time, place, and person. His performance score was 0, with a weight of 52 kg, height of 164, and BSA of 1.63 per meter square. BMI was 19.3 kilogram per meter square. So KPS was 90. The vitals were stable, and he was afebrile to touch. There was no pallor, icterus, edema, clubbing, or cyanosis. The CNS examination was within the normal limit and it showed no neurological deficit, whereas the other systemic examination, no abnormality was detected. Coming on to oral cavity examination, the on mouth opening, the inter-incisus distance was normal and was about 5 centimeter. Dental caries were present. Oral cavity was within normal limit. There were no any other suspicious lesion in the oral cavity, and oropharynx examination was also within normal limit. Nasal cavity examination, the external framework of the nose was within normal limit, and nasal cavity on inspection showed no normal mucosa and no visible lesion was seen.
How did you examine the nasal cavity?
Ma'am, firstly, I asked the patient about symptom, whether there was any pain or not. And after I made sure that there was no pain as such, I slowly palpated the external framework to know that whether there was any abnormality in the external framework and then with the help of my right thumb, I uh, uh, palpated the center uh, nostril of the patient and lifted it upwards to see the internal framework of the nasal cavity with the mucosa or whether any visible lesion was seen with the help of a torch.
So essentially, you've seen the external nares, right?
Yes, ma'am.
And the internal nares by lifting up the tip of the nose, right? That's
Yes,
your
ma'am.
inspection. Yeah. Okay. Go next.
Coming on to neck examination. On examination of the left neck, there was a 4 into 4 centimeter node, which was soft to firm, mildly tender, and fixed swelling involving level 2, 3, and 5 lymph nodes. On the right side of the neck, there was 5 to 5 centimeter firm, fixed, and tender swelling involving level 2, 3, and 5 level lymph node. The edge was well defined and surface over the swelling was smooth and regular. There were no other palpable nodes elsewhere in the body. The Hopkins was done. It was with the normal limit with bilateral cords mobile. So my provisional diagnosis will be locally advanced nasopharyngeal carcinoma.
Now, Harshdeep, how do you come to this diagnosis of nasopharyngeal carcinoma? What you have essentially elicited in your history, in your examination findings, I don't see any thing of a mass in the nasal cavity or the nasopharynx. How did you come to the diagnosis of nasopharyngeal cancer? Mihir,
Ma'am,
can you help him?
the
I'm saying the associated symptoms that he presented with like nodes in the neck and hearing loss and so
What do you
that's why,
do to
ma'am,
look
there is
at a thing, map the disease in the nasopharynx?
the most common presentation with which
No,
the
no, no,
patient
no,
will
no.
be.
Could you have
yes, ma'am.
done any other examination, or could you have asked somebody to do some examination for
Ma'am,
you?
endoscopy of or
Nasopharyngoscopy or a DNE could have been done, no?
yes,
So was
ma'am.
that
Yes.
done?
Yes, ma'am, it was done.
And what was the finding on that? That is also a part of examination, and actually that is an office examination, all right? So what
Okay.
did
Yes,
you,
ma'am.
what are the findings of the DNE or the nasopharyngoscopy?
Ma'am, it showed bulge on the right lateral side of the nasopharynx. I mentioned it, but actually it was there in examination, ma'am, but I think by mistake it has been removed, ma'am. The
Okay,
DNA
so
was
tell us
done
what is it?
on 22nd of March. It was done, ma'am, and it shows a disease bulge in the posterior and lateral wall of nasopharynx.
Okay, okay. So go ahead. So because based on this, you think it could be a nasopharyngeal cancer with bilateral lymphadenopathy.
Yes, ma'am.
What would you clinically stage this as so far?
Because, ma'am, bilateral node involvement
Hmm.
is there.
Hmm.
N2 will be the
Okay.
minimum stage I will be.
And then T stage?
T stage radiologically, ma'am, we will have to
Not
correlate.
radiologically. Just now I'm saying on based on the DNA and thing. Clinically, do you have a stage in mind? Or would you
Yes, ma'am.
call it what is the
Uh,
stage clinically?
on as the paravertebral, as a patient had
Shabnam,
next.
Mihir, please keep keeping in between.
Ma'am, the disease is involving lateral wall and posterior wall of the nasopharynx. So I'm suspecting the patient have like maybe parapharyngeal space involvement will be there. So I will stage him as a T2 for now, ma'am.
Okay, T2, N2, M0
Yes, ma'am.
or MX.
MX, ma'am, because no M0, ma'am. There is no symptoms of the distant meds for now, ma'am.
Okay. Anuj, Shweta, anything to ask? Or should we go ahead?
No, so I had a question to Hasdeep. So this
Yes.
was regarding the cranial nerve examination you told. So you were telling that most commonly it is oculomotor nerve. Do you think it is correct, Shapnam? Do you think that is the most common nerve involved? And what is the most common palsy that you see
Oh, did
first
he
in
say that? Did
nasopharyngeal
he say
cancer?
oculomotor
Oh,
nerve is the most commonly involved? No? Oh,
no, ma'am. The most common is cranial number 5 and cranial number
yeah.
6.
It's not five also. Yeah, it is
It is
6.
5. It is 5.
But you didn't
V1,
mention about
V2, V3.
abducens now. Yeah. So that was one comment. And what are the other? What about the other structures that are supplied? What is the superior oblique supplied by? Now supply
So for clear, ma'am.
trochlear. Okay. Okay.
So
Okay.
it is LR6 SO4. That is how
Yes,
you're
ma'am.
Yes,
supposed to
ma'am.
remember,
Yeah.
right?
That's what it
Yes,
is.
Ah.
Yeah.
Now tell me something, since we are still at the symptomatology, can you tell me a few syndromes, symptomatic syndromes associated with nasopharyngeal cancer? You said the
Yes,
fifth
ma'am.
nerve is most commonly involved, then you talked about the sixth nerve. Now tell me a few of the
So,
syndromes associated with nasopharyngeal cancer. Common
ma'am,
syndromes, don't tell me eclectic syndromes.
one syndrome I know about is Trotter syndrome, ma'am, in
Yeah,
nasopharyngeal
what is that?
carcinoma.
Trotter's
It is,
triad. What is it?
yeah, it is a triad in which there is a ipsilateral palatal paralysis, there is
Yeah,
ipsilateral temporoparietal neuralgia, and there is
okay.
ipsilateral conductive deafness due to eustachian
Very
tube
good.
obstruction.
Very good. What is Villaret's
Villarets, ma'am, I don't
or
have idea, ma'am. Sorry.
retroparotid syndrome? What do you, Shabnam, Mihir?
No, no, ma'am. I don't have any item. Sorry,
So
ma'am.
you people have not read about the syndromes associated with nasopharyngeal cancer.
And also,
This is very
Shabnam, I think you
important.
should initiate answering the questions
Yeah.
because you are the exam going, no? So I think you should answer equally what Hasdeep is answering.
Ma'am, in Villaret syndrome, Horner syndrome was included, but I'm not sure. It
Mm.
is.
No, so you people need to be prepared with all this. Otherwise, how? And Shabnam, please take the lead in answering these questions, because these are questions that are going to be answered. These are questions that can be asked to you in the exams, no?
Yes, sir.
We are yet to hear you. So do you know anything about these syndromes?
There is syndrome I have not read.
You know the retropathy, you know the Trotter's triad. But anyway, Harshdeep has already answered that. Which nerve is never involved in nasopharyngeal cancer?
Well, ma'am, spinal accessory,
How
11th.
can spinal accessory not be involved? It is one of the lower cranial nerves, no?
And
Facial nerve, seventh nerve.
Seventh nerve not involved. Very good. Read. These two things I want answers. Nobody's answering on the chat box or anything. You people don't come back with answers. Next time you won't have classes then. Okay, go ahead.
Ma'am, trochlear nerve.
Trochlear. Okay.
Yeah.
Yeah. Then go. Good. Whoever that one was. Chalo, go ahead.
coming on to the investigation findings, the routine labs done and
Anuj, anything else? Shweta, anything else?
No, that's okay.
Okay. Chalo, let's
No,
go
ma'am.
ahead. Investigations.
The viral markers were done and it were non-reactive. The investigations done included USG neck, which showed a hypoechoic lesion with no internal vascularity, and showed a size lesion of size 46 into 4.6 centimeter into 1.9 centimeter on the right side, level 1B. From the same finding, based on the USG, lymph node biopsy was done, which showed metastatic nasopharyngeal carcinoma, and immunohistochemistry showed positive for AE1 and AE3, P40, and EBV LMP1, that is latent membrane
What?
protein 1.
Okay, go ahead. Yeah. What else can you do on this histopathological sample?
Iberish can be done.
What is
In situ
Iberish?
Epstein-Barr virus in situ hybridization, ma'am. Encoded RNA in situ hybridization.
Yeah, RNA in situ hybridization. Okay. Arey yaar, Mihir and Shabnam, please answer questions.
Yes, ma'am.
Shabnam, what is P40? Why is P40 used as a test here? What is P40 done? Is it just done like that, or is there any? What is A1, A3? Whatever is there in the slide, you should be reading, right?
And A1, A3. Yeah, pardon, be a little louder.
Squamous differentiation presents with P40.
Okay, fine.
Okay, fine. Chalo. But because see, AE1, AE3, P40 are commonly used IHC markers. Okay. So you definitely need to know about them. Yeah. Chalo,
Yes,
next.
Then a PET-CT was done in the month of March, which showed a soft tissue lesion of 2.5.
Okay, 1 minute, Harshdeep, 1 minute. Okay, any which ways you. So what is the imaging of choice in nasopharyngeal? So now you're thinking this is a nasopharyngeal cancer, and is it okay, Anuj and Shweta, to go ahead with thinking it is nasopharyngeal cancer?
Yes, madam.
Okay. Now tell me something. So what will you do as your imaging modality of choice if you're suspecting a nasopharyngeal cancer?
Ma'am, it will be MRI.
MRI what of the toes?
MRI of PNS and neck. Face, PNS and neck.
What
With
about the base of
contrast.
skull? Will you include or not include? Will it be with contrast or not with contrast?
Yes, ma'am. It will be contrast and base of skull needs to be included.
And neck ke liye what will you do?
MRI, PNS and neck should also be included in that.
So which is a better modality for the neck? CT scan, MRI, PET-CT, USG?
For node, USG will be preferred, but amongst the imaging modalities.
How sure are you of that answer that you've said? That USG would be the preferred modality for neck? What is the biggest fallacy of an USG?
Observer variation, intra-observer variation.
So it is absolutely operator dependent. All right.
Yes, ma'am. Yes,
so
ma'am.
that is why a USG would be good if you do a USG with a guided FNAC for the nodes. But otherwise, for the neck, CT may be somewhat a little bit more superior to the MRI for the neck. So will
Yes,
you do
ma'am.
both?
Yes, ma'am.
Will you do both CT and MRI?
We'll do MRI with PET-CT, PET-CT.
Why not bone scan?
Patient didn't had any symptom of bony pain, so
So PET-CT, what are you doing it for?
Advanced disease, it's better to do PET-CT only. Otherwise, we can do CCT, head neck with abdomen with bone scan.
And MRI?
With MRI, but
MRI will be preferred.
Don't tell me can. Don't tell can. What
MRI
will you do? There is a patient in front of you.
Yes, ma'am. MRI should be done because local extent and any intracranial extension, if at all, if we are suspecting, then MRI will be more sensitive.
So you have to understand that in MRI, in nasopharyngeal cancer, if you are not doing a PET CCT, then both a CCT and an MRI would be ideal because they are complementary imaging. All right.
Yes,
So
ma'am.
if you're not doing a PET CCT and an MRI, all right. So what I'm saying is you need an MRI also, you need a CCT also. But what do? We do a one-stop, we do an investigation that is a one-stop shop, and that is PET CCT. Why? Because it gives us information about the local disease as well as of nodal disease and distant metastasis. But we also do an MRI, at least of the face, neck with PNS, including base of skull, because we want to know about the local extent. But can one of you tell me what are the advantages and disadvantages of the PET CECT in the loco-regional area? This, so we said that everything is very good about PET CECT, but what are the problems with PET CECT? Yeah. Who's talking? What are the advantages of PET? Can't hear you properly. Your voice is breaking, Shabnam, or is that my phone? I don't know.
As well as for response evaluation also. PET-CT can be used for planning also, ma'am. So
Really? Do you use it for planning upfront?
No,
Ma'am, the regional extent of the disease can be made out from PET CT.
What happens at the base of skull where there is so much of bone?
Uh,
What
there
if the
will be
node is
the
less than 5 millimeters in size?
because of the upgrade in uptake in a background, there are chances that we'll miss that node in the PET-CT, ma'am.
See, all of you know, when you are doing nasopharynx, you need to understand why we do a particular investigation and why not another investigation. What are the advantages of an MRI? What are the disadvantages of a PET CT? What does the PET CT not tell you about? And how does a PET CT compare to a CCT thorax, an upper abdomen, ultrasound abdomen pelvis, and a bone scan? These are things that you need to know when you are discussing a nasopharyngeal cancer, because everybody does not have access to PET CECT. Then are we doing harm to the patient by not doing a PET CECT and doing a CECT, USG, abdomen, pelvis, and a bone scan? You need to know this definitely with the percentages. Okay, so now go ahead with this case, Harshdeep. Hi, Harshdeep. Yeah.
Which involved posterior wall of nasopharynx and right fossa of Rosenmüller and right torus tuberis with an SUV of 11.94. It also showed infiltration into the adjacent parapharyngeal space. There was FTG avid bilateral retropharyngeal, bilateral cervical level 2, 3 lymph nodes with the largest of 3.9 into 2.4 centimeter with SUV of 15.7. There were no any other lesion which was seen. In the slide, we can see that this was a soft tissue lesion of 2.5 into 5.3 into 2.6 centimeter on the fused image. Correspondingly, this area we can see is the fossa of Rosenmüller, from which the soft tissue mass is arising and going towards the parapharyngeal space. Coming on to MRI, MRI showed 2 into 4 into 2.9 centimeter mass in the posterior and lateral walls of the nasopharynx on the right side, and it was crossing in midline. It also involved the fossa of Rosenmüller and eustachian tube opening with involvement of levator and tensor veli palatini muscle on the right side. There was no PNI involvement, no clivus, and no intracranial extension was present. There were multiple lymph nodes in bilateral parapharyngeal space, level 2, 3, 5, and litropharyngeal lymph nodes, with largest being 3.2 into 3.1 centimeter, that was right level 2. Then baseline, in TMH, what we do is we prefer a nasopharynx checklist so that we go in a systematic manner so that no investigations are missed. So in that checklist, the investigation which are included is baseline EBV DNA, which we do before any treatment is given, which came out to be 382.3 international units per ml, which was positive. And already the MRI PET-CT I have discussed, which we also include in the checklist. Then Ibarish was done, which also came to be positive. Then DNA was done, which showed disease bulge seen in the posterior and lateral wall of nasopharynx. In the baseline, before pre-chemo, we also make the patients undergo PTA, baseline pure tone audiometry, baseline TFT, and ophthalmologic evaluation. Here, in this case, pure tone audiometry showed a right mild conductive deafness, whereas on the left side, it was within normal limit. The baseline TFT and ophthalmologic evaluation were within normal limits.
So, Shabnam, tell me what is the mechanism of this right mild conductive deafness in this patient?
Due to eustachian tube obstruction on right side, there will be
because of the nasopharyngeal mass. You have to talk like that. Okay, next, go ahead.
So the final diagnosis here is a case of 25-year-old male with complaints of bilateral neck swelling, and on examination, the right as well as left side showed neck mass with involvement of level 2, 3 node on the left side and right side level 2, 3, 5 lymph node. Based on this, after histopathological evidence, we came to a diagnosis of locally advanced carcinoma nasopharynx, which is Epstein-Barr virus positive. And according to the AGCC 8th edition staging, the staging comes out, clinical staging comes out to be C, T2, N2, M0, and stage 3.
Any questions, any doubts, any comments at this stage before we go to management?
Why T2 and why not T3 here? Can you just tell how did you stage it as T2 here?
No bony invasion, sir. And from this picture, we can see that the central lesion, which is a nasopharyngeal mass, it is going up to the lateral parapharyngeal space, and it is not involving the bony structures. That is, the median and lateral pterygoid plates are not involved. It is only involving the soft tissue component corresponding to the median and lateral pterygoid plates, as well as it is involving the prevertebral muscles here. So also it can be considered as T2 and not T3.
No, but you told the pterygoid plates are not involved definitely. Has that been reported or?
Yes, sir. It has been reported in the MRI.
Okay, well, then it is wrong. The radiologist has reported it as a T3 mostly because it was abutting the medial pterygoid plate with reactive edema.
So tell me something, ye Shabnam,
Yes, ma'am.
when does it become a T3?
Ma'am, if bony structures are involved, like lateral and medial pterygoid bones, or clivus, or cervical vertebral bone. If bony structures are involved, then it will be T3, ma'am. But here only
And what
soft
about
tissues.
involvement of the medial pterygoid, the lateral pterygoid?
Medial and lateral pterygoid muscles will be included in T2, ma'am.
And what about disease extending to the lateral aspect of the lateral pterygoid?
Ma'am, it will be T4.
Very good. Chalo. Yeah, Anuj, continue, please.
So for nodal, what did you tell? Nodal involvement?
So as it showed level 2, 3, and 5 lymph node and retropharyngeal lymph nodes, it is coming, the lowermost extent was above the caudal border of cricoid cartilage. So we stage it as N2, sir.
Yeah. So what is the most common node that is primarily involved in nasopharyngeal cancer?
Retropharyngeal.
So lateral retropharyngeal node.
And
Do you know the name of?
And level 2, ma'am. Level 2.
And what is the pathognomic, I could call it, node of of nasopharyngeal cancer?
Retropharyngeal lymph node.
What is it called?
Name.
Echelon of.
What is that node called as? It's named after
Node
somebody.
of Ronvier.
Node of Ronvier.
Node of?
No, ma'am.
तो बोलो तुम बोल रहे हो सही लेकिन तुम गलत बोल रहे हो इसीलिए मैं पूछ रही हूँ फिर से नोड ऑफ Rouvier. What is the spelling?
Sorry.
You cannot make a mistake.
Rouvier.
So coming on to the treatment plan, this patient was planned for neoadjuvant chemo followed by chemoradiation. He underwent 3 cycles of NSCT of the chemo which were used in this patient were DCF regimen, that is doxorubicin, cisplatin, and 5-fluorouracil, the last dose of which was received on 12th June of 24. With concurrent weekly cisplatin. So he received 3 cycles of DCF with and he tolerated the regimen well. And then again the response assessment scan was done, which was PET-CECT. And it showed complete metabolic and morphological resolution of the primary soft tissue lesion, knolling nasopharynx, as well as the near complete morphological resolution of metastatic retropharyngeal and cervical nodes. We can see the comparison scan. This was a baseline PET CT, which showed a mass involving the fossa of Rosenmüller and the nodes. After 3 cycles of chemo, there was a complete morphological response. And these were the fused images which were taken into comparison, pre-chemo, post-chemo on the left and right side respectively. And the next slide. From here, Dr. Mihir will be taking that.
So I'll be talking about the discussion part of the nasopharynx, ma'am. So talking about the incidence and epidemiology, nasopharynx typically shows a bimodal age distribution with two age distribution groups. One is the 15 to 25 years and second is to 50 to 59 years. And male to female ratio is 2:1 or 3:1. And etiological factor consists of genetic factors, environmental factors, and viral factors, that is Epstein-Barr virus. Talking about India, there are high incidence of the nasopharyngeal cancer in the northeastern state, that is Nagaland and Manipur. The etiological factor we can discuss is first is genetic factor, that is HLA-A2 and HLA-B46 and HLA-17, that is associated with the high risk that increase the predilection of cells for the persistent Epstein-Barr virus infection, and that will result in nasopharyngeal carcinoma. The environmental factor shows that there is dimethyl nitrosamine that is in the salted fish typically consumed in China, that is responsible for the high incidence of the nasopharyngeal carcinoma there. Alcohol consumption and cigarette smoking and dust inhalation is also associated with nasopharyngeal carcinoma. Talking about the viral factor, it is EBV associated nasopharyngeal carcinomas are very common. It is because of the certain proteins that is produced by the Epstein-Barr virus, which will increase the predilection of the cells to get persistent infection with the Epstein-Barr virus, and then finally it will result in nasopharyngeal carcinoma. So talking about the symptoms
Can you tell
for
us a
the
little bit more? 1 minute, Mihir, can you tell us a little bit more about EBV per se?
So
You've talked about it being associated with nasopharyngeal carcinoma. So if you see the endemic population, everybody will have an EBV infection. So when is it off? When do you worry about the EBV infection?
So, ma'am, one thing we can do is plasma EBV DNA titer evaluation for the population which is at a high risk, ma'am. So
and then what do you do? Then what do you do? So you've had some people with very high titers. Then what do you do?
And then, ma'am, we can screen them for the regular screen
so
for the
you've done the EBV DNA levels in the plasma and you've got very high titers of EBV DNA. Then what do you do? So we're talking about people who've got very high titers. So what is done for screening typically?
We can ask for symptomatology for this patient on a regular screening.
So what is done typically in the screening programs in the endemic areas is these patients who have very high titers of EBV, you do directed scopies and directed CCTs to see whether there are any nasopharyngeal masses. So what happens? What is the result of the screening? The result is that it helps you detect nasopharyngeal cancer in lower stages, in earlier stages.
Yes, ma'am. Okay,
okay. You need to know that. Yeah.
Yes,
what is the other role of EBV? So one you said is diagnostic. The next thing is what?
Ma'am, it can be a prognostic significance also, like after we have given the treatment, what is the load of the EBV DNA
that
in the
talk
plasma?
about monitoring. That is monitoring. That is prognostic. Nahi hai. What is prognostic in EBV?
Ma'am, after we have given the treatment, we
Not
can
after baseline. Is there anything to do with estimation of EBV titers as baseline and that being a prognostic marker for outcomes? What you're saying is also correct, but you have to do it right from baseline. A single reading has no meaning. All right. So starting from diagnosis, monitoring, and then outcomes and persistence of EBV titers. Okay. So those are the things that will help you prognosticate. Then the third thing you said was monitoring treatment response.
Yes, ma'am.
You have to know all this. And EBV is what? A DNA virus or an RNA virus? And
It's a
what is its
DNA
size?
virus.
DNA virus. What is its size?
I'm not sure about the
So
size,
see,
ma'am.
now when you're talking about, now supposing somebody tells you about this, about HPV also, you need to know everything about that virus.
Oh, yes, ma'am.
Whether it's a DNA virus, whether it's an RNA virus, what is its size? Where is it lodged in the body? Okay, Shabnam, can
Yes,
you
ma'am.
help him? Shabnam, can you help him?
EBV is double-stranded virus.
Double-stranded what
Double-stranded-
virus? DNA or
double-stranded-
RNA?
Double-stranded DNA virus, ma'am.
What is its size? वायरस ऐसे ही पढ़ते थे ना माइक्रोबायोलॉजी में, साइज भी इंपॉर्टेंट होता है ना?
Yes,
Yes, ma'am.
So this is the second question that you're going to answer.
Yes, ma'am.
I want those answers. I'm not seeing any answers. Anyway, now go ahead. Anything else, Anuj, Shweta?
No, ma'am, it's okay. So, Shapnam, between EBV LMP1 and Eberish, if the EBV LMP1 is positive, do you think Eberish is required, or you can get away with Eberish? This patient underwent both the tests, no? Even though the EBV titers were high and EBV LMP is also positive. So, what additional thing you are going to get by doing an Eberish?
Sir, we can quantify maybe after doing the RNA.
My
Do you
question is
quantify?
different.
Do you quantify using Eberish?
No.
Based on hybridization, we can predict that whether it will be responding to chemotherapy or not.
No.
I'm also learning new
No.
things. Okay, ठीक है. Doesn't matter. Chalo. Yeah, Anuj, are you satisfied with that answer?
No, it is not the answer, Harshit. So, it is why is it done? Eberish, it is because it is highly specific for nasopharyngeal cancers, not for quantifying or assessing the response. Okay, so
sir.
if you have EBV LMP and EBV DNA titers, it is okay, rather than because Eberish is going to be costly also. So if you really want to do, you can do it. Sometimes you do
Okay.
Eberish when EBV LMP is equivocal or if it is negative or something like that. Okay.
Okay, sir. Yes.
Yeah. Now, which other
Yes.
malignancies are associated with EBV infection? Shabnam, any of the SR3s, JR3s? Which other malignancies are associated with EBV infection? जोर से बोलो, सुनाई नहीं दे रहा है.
Burkitt's lymphoma is associated with EBV.
Burkitt's lymphoma, very good, very good. Okay, chalo.
Further, neck mass, enlarged neck node. Patient may have a nasal discharge, bleeding, or obstruction. Patient can have auditory symptoms, tinnitus, and hearing impairment. Can have headache, cranial nerve palsies, neurological symptoms like ophthalmoplegia or diplopia, squints, facial numbness, and slurring of speech, weight loss, and trismus and distant mets, and dermatomyositis, that is paraneoplastic syndrome associated with nasopharyngeal carcinoma. So talking about the pattern of spread, the different type of the like different location of the spread will give rise to the different symptoms. So firstly, talking about the superior extension, first it can involve the sphenoid sinus. The sphenoid sinus involvement can lead to a headache, and further extension of the disease beyond the sphenoid sinus can lead to the cavernous sinus involvement, and then involvement of the oculomotor nerve and abduction nerve and ophthalmic division of the trigeminal nerve and maxillary division of the trigeminal nerve that can give rise to the facial pain and numbness due to maxillary nerve involvement. If there is abduction nerve involvement, it can give rise to the lateral rectus palsy and can lead to a diplopia. And if there is oculomotor nerve is involved, that can also lead to diplopia and squinting of the eyes because of the muscle like a palsy. And then talking about the anterior extension of the
1 minute.
Okay, what now?
Now tell me something. Where is this abducent? Sorry, sir, are you asking something? So tell me something. Where is this abducent nerve involved? And where is this oculomotor nerve involved in nasopharyngeal cancer?
Ma'am, after the cavernous sinus
Okay,
involvement.
ठीक है. So lateral wall of the cavernous sinus. So when you're
Yes,
talking
ma'am.
like this, no, just don't talk in one breath कि superior extent में abducent nerve involve हो सकता है, oculomotor nerve involve हो
Yes.
सकता है, ये ऐसा नहीं है. There is a particular
ma'am.
way in which things are involved.
Yes, ma'am.
Okay.
Should I
Monali,
go ahead,
anything
ma'am?
to ask? Please keep asking in between, huh?
Ma'am, but are we going to discuss management because it's already
No, then you
9:30
don't
and
take class on nasopharyngeal
okay.
cancer, no?
Okay.
No, I'm just saying that, huh? Because this is a full seminar then.
Yeah.
Okay, go ahead, go ahead. How many more slides do you have?
Ma'am.
Because, I wanted to actually come to the management of this case. We've not come to the management. Can we come to the management of this case?
Yes, ma'am. We can.
Yeah, so tell me so this was a T2N2M0 nasopharyngeal cancer in a 25-year-old boy, a 25-year-old man, and it was an undifferentiated nasopharyngeal cancer, right? With EBV titers that were positive. We have, because now we don't have a cutoff here in our institute, so we have this. So what is what would be your line of management? Or do you want to do anything more in this patient?
Stage and I think my workup is complete only. I've staged the disease. Now, for stage 3 and 4, for locally advanced nasopharyngeal cancers, we treat with chemoradiotherapy, and for other options are neoadjuvant, either with neoadjuvant chemotherapy or adjuvant chemotherapy.
So which has the best level supporting it? Neoadjuvant chemotherapy followed by CTRT or RT, neoadjuvant, no. Then what? Induction, what you call CTRT followed by adjuvant or CTRT. What is your level of evidence to support any of these approaches? Don't go by slides. मेरे को slides नहीं देखना है तुम्हारा.
Sorry. Ma'am, for neoadjuvant followed by CTRT, there is category 3.
Really, it is now category 3 evidence for neoadjuvant followed by CTRT. What is the evidence that you know of that supports the use of induction chemotherapy in nasopharyngeal, locally advanced nasopharyngeal cancer? Do you know of the evidence to support the use of induction chemotherapy? How do we treat this stage of nasopharyngeal cancer in TMH?
Chemotherapy followed by chemoradiotherapy.
How many cycles? See, whenever you talk about management, no, you're supposed to describe that management. So you will just not say induction chemotherapy. You will say 2 to 3 cycles of induction chemotherapy with gem cis platinum, followed by response assessment, followed by concurrent chemoradiotherapy. All that you will keep on rattling till somebody stops you. So what is the induction chemotherapy that you give this patient?
For this patient,
Shabnam, your voice now is cracking. Can you come closer to a mic, or I don't know, because I can't hear you clearly. I don't know whether it's a problem with my network, but please be clear. Yeah, bolo. I can't hear you. Anuj and Monali, can you hear her? I can't hear her.
No, not clear.
No net. I
It's
guess
just frequent.
where she is, the network is poor where she is, so that's why the voice is breaking.
How?
So,
Fine, ma'am.
Mihir, answer.
So, ma'am, we have treated this patient with neoadjuvant chemotherapy.
यार सुनाई नहीं दे रहा है तुम लोग कुछ करो अपना नेटवर्क का anybody else who knows what is the thing treatment and what is the evidence where are you quoting this from how do we treat it in TMH
There are many
Vaishnavi?
JR3s on the call.
Ma'am, the treatment, we treat with 2 to 3 cycles of neoadjuvant chemotherapy, usually the DCF regimen, which is docetaxel, cisplatin, and 5-fluorouracil, or gemcitabine plus cisplatin,
What
followed
are the
by
doses of docetaxel, cisplatinum, and 5-FU? And how are they given? What days? And how often are they repeated? You need to know the entire regime. Bolo?
Ma'am, docetaxel is given over 5 days as an IV infusion.
Dose?
Ma'am, it's 1,000.
मर जाएगा पेशेंट तुम्हारा.
Docetaxel is given in a dose of 95 milligram on day 1.
Very
Cisplatin
good.
is 60 mg on
Mm.
D1 and D2,
Seven.
and
Mm.
5-fluorouracil is given in a dose of 930 milligram on over
Very
the
good. What is
days.
the evidence telling you? What does the trial from Sun Yat-sen tell you? Sun का कितना dose है? चलो तुम्हारा स्लाइड दिखाओ उसके ऊपर. स्लाइड किधर है तुम्हारा उसके ऊपर?
इंडक्शन की
नहीं नहीं, don't show this slide. Show the slide by thing. Sun. Show. Go next. किधर है तुम्हारा इंडक्शन कीमो का? What is the trial that has set the stage for induction chemotherapy?
I think
Where is your induction therapy ka trial? Where are the Lancet Oncology trials? Where are they?
And Harshdeep, what dose did you tell? I didn't hear.
9. Hello.
Hello? Yeah.
कुछ तो मिहिर ने बोला doses.
Sir,
95?
docetaxel is 95, cisplatin is 60 milligram on day 1 and day 2, and 5-fluorouracil is 930 milligram on day 1 to day 5, which is given every, these 3 cycles are given on a 21-day gap, sir.
This 930 milligram, where did you get?
Yeah,
Normally, I
where
don't
did you
remember
get? I don't know.
reading this 930 milligram. It should be milligram per meter square, no?
Sir, for this patient itself, the
This
medical
patient,
No,
it's not for
that
this
is why I'm
patient.
asking you. Where is the
Okay.
Sunka trial? Where is it? I don't
Ma'am.
see. Is this trial there here in your presentation? Which are the 2 trials that you will mention when you're talking about induction chemotherapy in your nasopharyngeal cancers? Tell me. One is the DCF trial and one is the Cisplatin. Yeah. So can you remember the names of the first authors? Even if you don't remember, there is a difference in the dose schedules that are practiced in DCF in that trial versus what we do. Their doses are lower than our doses. Okay. But it cannot be 930 milligram per meter square. It is not 930 milligram per meter square. I want that trial. Show me where are the trials in your presentation.
We have included only one trial.
Where is that trial? Show me that trial.
This one.
This is not a trial. See what is the title. It is a systematic review and a meta-analysis. There is a difference. What is the difference between a trial and a systematic review and meta-analysis? Now see, this is how you will lead the examiner in your exam also. What is a systematic review and meta-analysis versus a trial?
Review.
So please be clear on that and don't insist that this is a trial. This is not a trial. Where are the things? Shortcut yahan pe mat mara karo because it is a problem. You have to know the induction trials. So one is by Sun and the other one is? Will you all please read up those 2 also and then come to this meta-analysis? So today it is not category 3. So you have induction chemotherapy followed by concurrent CTRT. So in this patient, what was done?
Induction chemotherapy followed by CTRT.
So after induction chemotherapy, do you do anything?
Response assessment scan for to see the response of the maybe response PET-C CT scan, ma'am.
Why do you want to do a PET-C CT? Spend the
So, ma'am,
patient's money.
Metabolic response as well as disease response.
ma'am, morphological and metabolical
You,
response to
तुमको morphologic and metabolic, we are not in an ideal world. What do you do in your clinics? This is a non-metastatic nasopharyngeal cancer to begin with. What are you interested in proving unless you have some symptoms or something to suggest that there has been progression at distant sites? What would you do in this patient? Normally, you would do an MRI locoregional only, right? To see what has happened to the
Yes, ma'am.
disease. And
Yes,
then
ma'am.
after that, you would do CTRT.
Yes,
Now
ma'am.
go to your next slides. Do you have any slides on radiotherapy? No 2D technique. 2D technique karna hai, sir? I don't know.
Oh, no, I think we can skip the 2D
So is there
technique.
evidence?
So why we
So
don't do
tell me
2D
something. Do
technique?
you have? Why do you not do 2D in nasopharyngeal cancer preferentially? Tell me. Sir is asking that.
For a glottic cancer, you can still do 2D, but for a nasopharynx, we would strongly advise against. Why?
Nasopharynx is surrounded by critical structures like brainstem and spinal cord and optic
bolo.
and all the foramens which through which nerves passes and
No. 1 minute. The foramina through which the nerves must, are they a part of your CTV or are you going to spare them?
you want to spare them, ma'am.
Huh?
Oh,
No, ma'am. They
want
are
to
the
spare
part
them.
of the CTV, ma'am. They are the part of the CTV, ma'am.
And why are they a part of the CTV, Shabnam?
Ma'am, because the nasopharyngeal carcinoma tend to
Mihir, I'm asking Shabnam, 1 minute, wait. Then you can help her if she doesn't know the answer. Shabnam, your exam going, that is why we are asking you again and again. So today you will go back and read nasopharyngeal cancer, okay?
Yes.
So you said you were correct about saying that it is very close to critical structures like the brainstem, the optic nerves, the optic chiasm. So what happens? So then you have this. So then what happens if you do 2D planning in these areas?
For ma'am, due to 2D planning, the chances of temporal lobe necrosis will be very high.
But तुमने temporal lobe को तो critical structure बोला ही नहीं.
I think let them quickly go through the slides and we'll have some questions. So just so this is your GTV delineation. Okay. How many more slides you have on radiotherapy? 7, 8 slides?
Yes.
Well, just one by just spend a few seconds on each slide. So GTV delineation that you will do. Then so okay for the primary and the nodes. Next. Just say 1 or 2 lines on each slide and keep on moving also.
So for GTV primary, it's a primary tumor and involved nodes.
Okay.
Risk CTV, we will include high risk primary disease, which is GTV primary plus 5 mm margin or surrounding critical structures. We will give 1 mm margin only, and we will crop from air cavities and bone. And for CTV nodal disease, we will give GTV nodal plus 5 mm margin, and for intermediate risk disease, we will include the remaining nasopharynx, the anterior 1/3, anterior 5 mm of nasal cavity, anterior 5 mm of maxillary sinus.
Yeah, you don't have to read through everything. You can skip. You don't have to read through. People can read the slide later on. Carry on.
For low risk CTV, will include the elective nodal volumes if they are not involved. They will be from level 2 to level 5 and retropharyngeal if not involved. Then for
so 1 minute, Shabnam, 1 minute. Do the guidelines describe an intermediate risk volume? What is that intermediate risk volume? Don't read your slide, please. For both the primary as well as your node.
For nodal,
primary, what is the intermediate? For the primary, what is your thing, CTV IR? What are the structures included? You have to know this. Okay? You have to know this. Now, intermediate risk N, you have already got your slide on. Forget it. I'm not asking you this. Go next.
So for
Okay.
PTV, we will give 3 to 5 mm margins.
This 3 to 5 mm, who determines it? For the primary, you will give 3 mm or 5 mm, and for the neck, you will give 3 mm or 5 mm.
For primary, we will give 3 mm. Or
Why?
for nodal, we will give 5 mm margins.
No, but why? Because the guidelines tell you to do this, or because of some other reason? What determines your PTV expansion?
Movement will be more at nodal neck level than at primary level.
Okay.
And critical
That is the right,
structures
that is
are
correct. But then, no. But see, how do you determine your PTV expansion from your CTV? Who tells you how much to do? So this is basic radiotherapy. Okay, so you have to know this answer. All right, Shabnam? Shabnam, Mihir, Harshdeep, कौन answer देगा? PTV, what is the expansion of the PTV? 3 mm, 5 mm, and why? Why is there a difference?
Ma'am, it's a 5 mm because of the setup variability, random setup errors. To consider the random setup errors, and we consider the movement of the organs that we are delineating.
So इसमें कौन सा क्या ITV होता है इसमें? कहाँ पे movement होता है?
Ma'am, for nasopharynx, there will be movements will be very less, but maybe PTV will be generated for the setup errors, ma'am. Random.
So it is institutional, the PTV, right?
Guidelines.
You have done
Yes, ma'am.
pura. Chalo, next, go next. What is your dose schedule?
for PTV high risk we give 70 gray at 2.12 gray per fraction. For intermediate risk we give 59.4 at 1.8 gray per fraction, and for low risk we give 54 gray at 1.6 gray per fraction. So for this and
what is the total number of fractions? You have not told. I mean, you have to calculate and figure it out.
35 fractions.
Okay, so basically you are giving 70 gray in 35 fractions.
Yes.
So then you, if you're doing, sorry sir,
yeah,
if you're doing SIB here, what will be the dose? 1735. That is a 2 gray per fraction. It is not a 2.22 gray per fraction.
yeah.
Otherwise, it will have to be a 70 gray in 33 fractions. ये सब रटके होना चाहिए शबनम. So if you say 70 gray in 2 gray per fraction, it will be 70 gray, 35 fractions. Then your intermediate risk will receive 60 gray, 63 gray, 35 fractions, and your low risk will receive 56 gray in 35 fractions. Samjha?
And whenever you describe a radiotherapy prescription, total number of fractions have to be there. You don't leave it to others to calculate what will be the total number of fractions. Come on, next. What are the other slides? Quickly, we'll finish. Constraints. Oh, we will not go into that. Constraints. Okay,
but please,
next.
Padna. Please, Padna.
Yeah. You have to know. Next. Constraints. Treatment-related toxicities. Okay. Are there any unusual toxicities other than what we get for other head and neck cancers? What?
Temporal lobe necrosis.
Temporal lobe. And acute toxicities, how is it different from other? So, of all the head and neck cancers, the maximum amount of mucosal and salivary tissue irradiation is in nasopharynx. Okay, so that also you have to keep that in mind.
Yes.
Okay. Next plan. We won't have to go into details of this. You can skip this. Next. Dose prescription. Next. Okay, so this is your plan. This is for this patient.
Yes.
So have you elongated the slides or they are true this thing? This looks like a giraffe neck to me.
No, but Tell me something, Shabnam. This pink volume that you have is the high risk volume.
Yes, ma'am, it is high risk volume, ma'am. It involves
What is good, bad, and ugly about this plan? If I were to ask you to evaluate this plan, tell me.
We are treating nasopharynx with level 2, 3, and 4 lymph nodes in high risk volume. So the volume is large, so toxicities will be more, ma'am. In 95% coverage is. Hello.
Ma'am,
Level
your
5,
voice.
what do we do?
If level 5 is involved, then we will take in high risk volume. If it is
But
not
he
involved,
told me that there were level 5 nodes also, no?
yes, ma'am. Level 5 it was involved, ma'am. But
Actually, ma'am, for this patient, level 5 was involved, but it was in a low risk volume. So we don't understand this, ma'am, actually.
Okay, ठीक है. You are just showing this plan.
Okay.
Yes, ma'am. Yes.
Next.
All right.
So
Ma'am, your voice is breaking, ma'am.
yeah, Sharvani, your voice is breaking.
Okay.
So, nasopharynx is one of the most difficult site in head and neck cancers. So it is very different from all other head and neck cancers because the etiology is different, the geoethnic distribution is different, the risk factors are different, the OARs, new OARs are added in addition to the other OARs, and the technique is also different. So I think all of you, can you hear me?
Yes, sir.
Yeah. So you all answered very well when Dr. Sharvani asked you about the negative history or positive history. I think Harshdeep or whoever was answered it very well. When we were talking about how different imaging modalities or staging modalities complement each other, I think you all were a little confused and could not answer properly. The in terms of the etiology, so one word you should have used that there are marked geoethnic differences. You all mentioned, but this is one cancer where there's very marked both geographical as well as ethnic differences around the world, across the world, and also in India. So that should have been highlighted.
Yes, sir.
EBV part, you all covered most of it, but not all of it. In terms of when Dr. Sharmani was asking about the various cranial nerves from which sort of holes or apertures they go in, go out, how they explain some of the symptoms, some of you could not answer it properly. So I think all of you have to read a lot. This is again, go through the slide seminar and read again. Nasopharynx is one thing you have to understand all the concepts, everything from how the symptomatology is produced, how the volume is delineated, what is to be covered, what is not to be covered. Shabnam was saying something as an OAR. Okay. Some of the foramen oval, something she was saying as OAR, whether it should be covered or it's an OAR. So all those things you have to know it well. I think Sharvani has already brought out all the aspects during the presentation. Radiotherapy part, you all read in little bit more detail. Sharvani, you are there. So for your comments.
I'm there. I agree with all the comments that you've made. You need to read all this, and especially you will not be pardoned if you do not know the trials on induction chemotherapy.
Yes.
That is
Yes.
the flow for regionally advanced nasopharyngeal cancers today. So you definitely have to know this. And you
That's true.
cannot show one meta-analysis. And if somebody asks you, what is the difference between a trial and a systematic review? And
That's true. That's very important.
Okay,
Okay.
please read.
And all the questions that were asked, we'll tell all of you, please put in the chat box in the YouTube live stream, put in the chat box the answer, write the question and then answer those questions. So in the past presentation also, all of you do that. So with this, we end the head and neck. So Sharbani, Anuj, Shwetab and all others who participated really, I think in 7 or 8 quad rounds, we have finished the entire head and neck. And for the exam going batch, you have to go through this, what you are asking for lectures. Okay.
One doubt can I ask, sir?
Yeah.
There was one big head in the OPD He was asking about what can be the expected visual side effects. So, how do we have to counsel the patient post RT that whether, if at all,
So
there
see,
will.
you have to know what is the tolerance of optic nerve. Okay, 5/5, 5/50, what? And it is not just the dose and dose per fraction. So you have to know how much is the dose to the optic chiasm or the optic nerves accordingly. Other is sometimes acute toxicity. So there's no one generic answer. You have to figure out and then tell the patient accordingly. Okay. That is
Thank
true
you,
for
sir.
all cancers which are near the base skull or other side. That is true for all. Most of the times, our patients don't ask us specific questions. So we just tell something general and then we get away with it. But ideally, for each patient, because this is you can tell after the planning, you know which which critical organs are getting what dose and what dose per